The Curbsiders are now partnering with VCU Health Continuing Education to offer CE credits for physicians and other healthcare professionals. Check out curbsiders.vcuhealth.org for more information.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cashlight Memorial Hospital and its affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders.
Hi, Carolyn.
Hey, how are you, Stuart? It's been a while.
I'm doing okay.
So this is a weird one, guys, because you might notice that Matt is not here, and without our anchor, this ship is just drifting at sea. Listen, we did great, and I feel like too often when you hear the term dead weight, it's heard as a negative, but I think we flew without Watto. I think without him dragging us behind, we actually soared, and we're finally put together an episode I can be proud of. So long live the Curbsiders. Yeah, farewell,
That's
Watto.
Right. Paul,
who's sitting in the dark right now.
Speaking of which, why do we do this, Paul?
Great question. Mostly for the money. But if you're asking what we do, we are the Internal Medicine Podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge.
Oh, that's correct.
And boy, do we have an expert interview for you today. I'm going to let Carolyn Chan, the wonderful Carolyn Chan, tell us about who we talked to and what we talked about.
Yeah, we have an absolutely amazing episode lined up for you guys today. We have dedicated this episode to talking about how do we care for patients in the hospital with substance use disorders. So we're going to talk about a lot of common scenarios that we may see, like managing patients who have pain and also have opioid use disorder. We talk a lot about how important it is to address and manage and treat the underlying addiction, as well as what do we do when you have an individual who's on methadone treatment and prolonged QT. We talked to the fantastic Dr. Melissa Weimer. She is a clinician educator who is a board certified in internal medicine and addiction medicine. She is the medical director of the Yale Addiction Medicine Consult Service. Dr. Weimer has a clinical and research focus on expanding access to and improving treatment for patients with substance use disorders, particularly in the hospital setting. She is also extraordinarily passionate about expanding the workforce of healthcare professionals who treat patients with substance use disorders. She teaches us a bunch of wonderful pearls. So without further ado, let's get to the episode.
All right. So Melissa, thank you so much for joining us. We're really excited to have you on the show. As is our way, we're going to start with some getting to know you questions. And the very first one that we ask every single time would be, please give us a one-liner to describe yourself.
Great. Thank you. I am a 41-year-old woman in medicine, addiction medicine physician, mother of two, wife to a talented artist husband, anti-racist, and lover of sprinting on my treadmill, who strives hard to improve the treatment of patients with substance use disorder.
And the treadmill specifically? I know that's a weird thing to anchor to.
Yeah, like sprint on the treadmill.
Yeah, it's very specific. I have found, particularly in COVID times, that things can get stressful and you need a real outlet. And sprinting, specifically, on a treadmill is a strong outlet for me.
So in the BC time, the before COVID, you weren't sprinting on the treadmill?
I was, but probably not as aggressively. Intentionally.
Sure, yeah.
So a few things. I have a treadmill desk that I've created so that I can walk during meetings, which go on for way too many hours of my day. And then if I'm just feeling stressed, I can just get on there and like pump it up to, 8, 9, 10. And it's amazing. Endorphin rush and you're good.
Do you ever start sprinting when you get really angry during a meeting, just as you feel like it should be done by now? Let's get this out.
Usually that's frowned upon. My colleagues will usually hear me walking and sort of be like, what is that noise? And then I have to explain, and then I explain my setup. I think they've sort of figured it out at this point, but yeah, generally I keep it low during the meetings.
What's all this heavy breathing during the pharmacy and therapeutics meeting?
I can increase the incline if I'm really bored. That can sometimes help.
Wow. I would love to see a meeting where everyone's doing that.
It would be a lot healthier, right? I think the
funnier.
meeting, it would be funny and it would probably be much more efficient.
Yeah, they'd be shorter for sure.
Yes.
Yeah. So what's your favorite failure and what'd you learn from that?
Wow. So when I was a second year resident, I did not get into the ICU fellowship at my own institution, and I was devastated. And the thing I learned was that I was not meant to be an ICU doc. Instead, I was meant to be an intense physician of a different kind. And so what I do now is addiction medicine. And quite honestly, as heartbreaking as it was at the time, that was absolutely what was meant to happen in my life.
That seems to be a recurring theme. Yeah, that great answer. And it's something that has come up before where you ended up was not where you initially planned to go, but you're incredibly happy where you are. Not that I'm going to put that on you necessarily, but you seem to be.
Yes, I'm very happy. And I mean, I think I would have been happy doing ICU medicine as well, but it was really an opportunity to rethink things. And that is hard when you kind of have your mindset on something. But in that rethinking, it really opened up a lot of doors for me.
I'm sorry, Paul. I just have to ask this. I'm so sorry. I'm going to say it ahead of time. Hey, Melissa, do you know what the most intense kind of physician is?
No.
A wilderness medicine physician.
I don't know. I think addiction medicine might be more intense.
No. They're actually intense.
Yes. We don't see actually, sometimes we do see our patients intense. So I might challenge that answer.
We can edit around all this, by the way.
And on that note, what is a book that every physician should read?
So I was struggling a bit with this because I don't read a lot for pleasure. I know a lot of people who do, and it's just, I just don't have the time. But there is a book that I love that for me was important to help me think about living more in the moment, and that is Pilgrim at Tinker Creek by Annie Dillard. It's my all-time favorite book.
That's such a great book.
Even the first sentence of that book is like so amazing. I remember the first sentence of that book. I can't say I remember the first sentence of any other book.
Well, call me Ishmael, but yeah, there's I think that is the prologue or the first chapter where she talks about her cat walking on her, leaving bloody footprints like rose petals. Like it's just it's so beautiful.
It is. And it was written about my home state, Virginia. So that also kind of makes it dear to me.
All right. Excellent choice. High recommend. So that'll be my pick of the week. And we could transition. Stuart, do you have anything that has been entertaining you that you've been enjoying recently?
Oh, I've just been binging on The Last Kingdom on Netflix. Love the interplay between the Saxons and the Danes and the historical references. I'm a huge Dark Ages and medieval history guy. Even though it deviates from history dramatically, it's actually a pretty good series.
I am completely unfamiliar with it.
It's great. It's wonderful. It takes place in, I think, about 900 AD, give or take, with one of the first Danish invasions of Anglo-Saxon England before the Saxons were united. And so you have like 4 different Saxon kingdoms in England during that time that were disparately trying to fend off the Danes, and every single kingdom was invaded and taken over by the Danes except for Wessex.
That would have been my guess. Yeah. No, so you know how it turns out then.
No, that's just the beginning. It's like episode 1.
That's episode 1? Oh my goodness. That sounds
Oh, it's wonderful. It's great.
I feel like I've gone on sort of the opposite end where I've been watching like mindless, like just good television. So I've been currently binge watching The Good Place. So it's like this comedy about what happens after a group of strangers sort of pass away. So like, what is the afterlife like? And it's really a fun premise. So if you're looking for something lighter to just binge, I highly recommend it.
Is that the one where like the husband and wife are like, she hates him or something, Is that? No, I can't remember what it was.
It's not. No, it's all like 4 single people. Everybody is everyone. It's a lot happier.
There's another series
nobody hates anybody quite yet.
Where the husband and wife pass away, and they're in a ethereal like this subdivision, but they hate each other, and they want to get. And the wife tries to get away from the entire time. I'd have to go find that series. It's pretty hilarious.
All right. Well, that sounds excellent. I was going to say the series where the husband and wife hate each other could be every sitcom on television, but the death, I guess, narrows it down somewhat. And with that, I mean, this feels like a chance to sort of smoothly transition into our first case. So let's move on from our picks. Let's actually talk about what we came here to talk about. And Carolyn, why don't you introduce our first case for Melissa?
Yeah, we have a couple of great cases for you guys today. So for our first case, we have Miss Polly Sudds. She is a 42-year-old female with a history of anxiety who was admitted for acute intoxication after she was being found just wandering outside by police. Her urine toxicology is positive for amphetamines, alcohol, opioids, and benzos. The patient is diagnosed with encephalopathy due to polysubstance intoxication, and she appears agitated, tremulous, and screams that she's withdrawing. She reports daily alcohol, heroin, and benzo use for the past 3 years. But this is the first time she's actually tested positive for a urine tox for amphetamine. And on a prescription drug monitoring program, you notice that her PCP also intermittently prescribes her oral lorazepam for anxiety, and she reports illicit use as well. So, Melissa, our first question to kick it off is when do you decide to order an inpatient urine tox screen? Do you do it on every patient? How would you sort of discuss the results if you have an unexpected finding?
Well, generally these are patients that are coming into the hospital with some sort of indication where you're trying to figure out what's going on, and you want to make sure that you're addressing anything that could potentially be fatal. So we do it as a universal screening. So every patient, essentially, as part of addiction medicine evaluation, would generally receive a urine drug test. What you test is important. Given the contamination of our drug supply, we usually also test for fentanyl because many people are exposed to fentanyl and they may not know. So that's generally an add-on. And then for someone like her, I would probably also make sure that I'm checking an alcohol panel and an alcohol level because we see a lot of patients who are repeatedly admitted for alcohol, but never really have any objective measure of their alcohol use. And it can be an important indicator for the severity of their potential withdrawal. If they come in with an alcohol level of greater than 350 or 400, that really can dictate how you treat them. So I would kind of think of a urine drug test like an EKG for addiction medicine. It's part of the objective information that we obtain to guide our diagnosis and treatment.
And obviously this will differ. So you wouldn't discuss the results necessarily with the patient if they're acutely intoxicated or acutely encephalopathic. But when the dust settles and you're sort of having the conversation, the patient's perhaps a little bit more lucid. How do you discuss the results with them? How do you discuss the findings of the urine toxicology without seeming accusatory?
Generally, it's really, like I said, a piece of information. We don't necessarily directly discuss it unless there's a concern, that they're not necessarily providing us all of the history that we need. So, this patient, you have a concern about potential benzodiazepine use, and that could affect ongoing treatment. So if when I'm obtaining the history from the patient and the patient doesn't really say anything to me about benzos, I might probe a little bit and say, hey, your urine drug test showed benzodiazepines. Could you tell me a little bit more about that? And it's really kind of matter of fact. And really, when you're having this conversation with people or you're obtaining this history, I think when you're just very open, honest, non-judgmental, I find at least that the people tell you what's going on. And then if they don't, that tells you something else, right? That tells you that they're concerned for some reason and they don't want to share this. So I might also kind of probe a little bit and say, I've seen that you've come in several times maybe with benzodiazepines. I'm really concerned that this is something we need to address. Sounds like you're struggling with. How can we best help you with that? And again, people are generally pretty open.
No, and I like that approach. I feel like I run into this. I'm framing it in terms of my outpatient practice, and particularly buprenorphine clinic. Sort of when the urine toxicology is discordant with the patient's history, and just sort of how do you have that conversation in a way that does not feel like a gotcha, which is not what I'm going after. But I feel like it sort of warrants discussion. So I sort of like that framing of it for that context as well.
I mean, I think a lot of the times the issues that come up when we're talking with patients are really sometimes can be our own baggage of how comfortable we feel talking to patients. So having, now being in practice for 10 years, talking to patients about all kinds of drug use, I feel pretty comfortable and confident talking to people and just really making it a normative conversation. But what I see a lot for learners or people who aren't feeling very comfortable discussing addiction, they'll sometimes tiptoe around it, and patients will not feel comfortable if you don't feel comfortable.
All right, so let's go back to our case. So Ms. Suds, all-time great name, has what looks like polysubstance withdrawal, possibly, or at least it's kind of hard to tease out exactly what agitation is what's contributing to her current agitation. So what would be your sort of initial approach to this patient in terms of sort of working her up and even sort of managing her symptoms?
Sure. So again, as much objective information as you can obtain is the best. So we have scales that we utilize to monitor withdrawal. So for alcohol, we utilize, typically many hospitals have the CEWA-AR, which is the revised alcohol withdrawal protocol, or not protocol, but scale to determine how severe someone's alcohol withdrawal is. And then you can additionally, because this patient is also reporting opioid use, do a clinical opioid withdrawal scale, or a COWS, and you can do both at the same time. Is there some overlap? Absolutely, but they're looking at different factors. So CEWA-AR is really looking at more of like tremulousness, hallucination, factors like that, where the COWS, the clinical opioid withdrawal scale, is really looking more for like pupillary dilation, goose flesh, joint aches, things like that. So they are distinctly different. We do sometimes see people utilize one for the other, and so it's important to know the difference. So really look for those objective signs. Make sure that you're treating the benzodiazepine or alcohol withdrawal probably first, since that could be fatal and you don't want to miss that. So you'd want to likely start a benzodiazepine, which is typically our gold standard. There are other agents you can use, like phenobarbital, which can sometimes is being needed to use now because there's some shortages of IV, particularly IV benzodiazepines. And then you want to make sure that you're repleting vitamins, minerals, which are typically depleted in patients with particularly alcohol use disorder.
Is there a specific benzodiazepine that you would use for this patient or for any patient with alcohol or benzodiazepine withdrawal syndrome?
Usually it depends on their other labs. So if they come in and they have very concerning liver abnormalities, for instance, you'd want to use a benzodiazepine that isn't metabolized through the liver. So you'd probably use something like lorazepam. You'd probably avoid something like chlordiazepoxide. But each institution seems to have their own kind of benzo fave, if you will. And the one that I think is probably underutilized but seems to work pretty well for most people is diazepam. The reason it tends to work a little bit better is it's a longer acting than the lorazepam, and just seems to not have as many concerning metabolites and things like that.
I think it's really hard to managing patients who are on benzos, especially in the hospital. So let's say that this patient, let's say that she tells you that she takes benzos for her anxiety, and that it's the only thing that has sort of helped after she's sort of improving from a withdrawal. So how do you sort of approach the management of a patient who takes sort of prescribed and illicit benzo use, especially if they're in the hospital and you're only going to see them, for kind of a brief period of time?
Right. I think this is really increasingly becoming more of an issue. At least we've been seeing more patients coming in with really serious benzodiazepine withdrawal. And unfortunately, sometimes they're using such high doses that we're really giving doses that we don't otherwise feel comfortable with. For benzodiazepine withdrawal, unlike alcohol withdrawal, which has pretty good data for symptom-triggered treatment, benzodiazepine withdrawal, typically in my experience, patients do better with a scheduled taper. The things you have to be careful about, particularly if there's alcohol and benzos together, is that they're probably really going to need a fair amount of the benzo. So what do you feel comfortable giving? These are the times when utilizing other agents like phenobarbital may be something to have in your pocket. Just to kind of calm things down a little bit. Phenobarbital is so long acting that it really can kind of help soothe some of that really serious, severe withdrawal. But you also want to utilize your other non-benzo agents like hydroxyzine. You can use clonidine as long as their vital signs are stable. So utilize all those additional agents as well, because a lot of the concomitant anxiety, fear of being in the hospital can contribute to their overall withdrawal syndrome. That being said, certainly if they're not getting better, they're starting to have hallucinations, they're really unstable, you may need to consider transition to a higher level of care, like the ICU, utilizing other agents like dexmedetomidine and agents like that.
And let's briefly take alcohol out of the picture. If you're trying to sort of taper someone off in the inpatient setting, and you have a schedule, how quickly does that occur?
Right. So it really kind of depends on how much they're utilizing, and then how long you're able to keep them in the hospital. Increasingly we are measured by our length of stay and other factors, and many payers may not want to pay for just a benzo taper. So I think you have to take all those things into account. We do generally do the tapers pretty aggressively. So kind of think about what is the top amount that they report, and then you have to kind of get into a sweet spot of what you think is going to be easy to taper, what they're going to tolerate. And then generally we reduce the total dose by 20 to 30% per day from there every day. You don't have to necessarily keep them in the hospital to do the taper, but you would want to partner with their family, get them a lockbox or something else to help safeguard the medication on discharge. So there are different ways you have to think about, if I'm going to discharge this patient on benzodiazepines and a taper, how do I think about keeping them safe? So whether that's someone giving them the medication or working with a family member or close follow-up, those are all different options.
So I'm curious, in your experience, how many days on average are you getting people to complete these benzo tapers for someone you would typically see? Not the extremes, just the mean.
I mean, usually, quite honestly, most people struggle extremely with these tapers. So when we are able and they have close follow-up that we can arrange, we typically try to facilitate ongoing care in the outpatient setting with close follow-up. And then depending on there are other drugs they're using, other factors in their life, we may shoot for a 2 to 4 week taper. So obviously that's not happening in the hospital. For patients who've really struggled, who have severe benzodiazepine use disorder, they may need a much longer, prolonged taper, and that could be the longest taper that I've helped a patient with, and she actually did really well, was a year.
And I believe it. What about, let's make this even more complicated and challenging. So what if this patient, let's say day 2, we have a very thoughtful, we address the symptoms of withdrawal very thoughtfully. We have a pretty good scheduled taper in place. And from an agitation standpoint, they're feeling better. Let's say the CWA was 12 down from 18 and their CAL score is around 4. So maybe sort of mild withdrawal symptoms from the benzodiazepines and really minimal withdrawal symptoms from the opiate use, and the patient feels so good that she would just like to go home. She's like, I'm done. I think I'll take it from here. What should our level of comfort be with prescribing, say, like an outpatient benzodiazepine taper? Is that something that is done in practicality?
Definitely. I mean, I think everyone's has different levels of comfort, but again, if you can help safeguard the medication, have close follow-up, or complete the taper in, say, 3 to 5 days, then I would say that, there's not a reason to keep them in the hospital for that indication only.
Gotcha. And then I guess the other safety question I would ask, and I feel like this is more of an issue in the past, but I seem to recall there being a lot of concern about combining, say, buprenorphine and benzodiazepines, or using buprenorphine for someone who has, say, comorbid alcohol use disorder. How limited should we feel by those things? And I know that's sort of a long-winded question, but if someone has concomitant alcohol use, should that stop us from prescribing other possible medications for their substance use disorders?
I think that you should think about, ways that you can get that person some treatment for their alcohol use or their benzodiazepine use, support them in other ways, but I would not stop their buprenorphine. I would absolutely continue it, because we know that there's such a benefit for mortality and so many other factors with buprenorphine. So that doesn't mean you shouldn't monitor them. You shouldn't try to work with them to abstain from alcohol or benzodiazepines, but we do not stop the buprenorphine in those cases. I would just say, thinking of agents you could use for the alcohol would be acamprosate or disulfiram. Naltrexone is obviously a great medication for alcohol use disorder, but because it's an opioid antagonist, you can't utilize it with buprenorphine.
Okay, excellent. Carolyn, was there anything else out of this case that you had any questions about?
I'm a little bit curious. I feel like there's so much overlap actually between the way we treat benzo withdrawal and alcohol withdrawal. Do you approach them really truly differently? I feel like we're using a lot of the same medications, in terms of thinking about the taper. And
I think I'm supposed to say yes, but honestly, I don't really, because so the CWA-AR is not validated for benzodiazepine withdrawal, just to be clear. There is something called a CWA-B, which was meant to be utilized for benzodiazepines, but honestly, it's not really that different. So, I do typically kind of utilize the CWA-AR for that purpose. However, like I said, generally patients who are using high-dose benzos, I think the difference would be those are patients who really are likely going to need a taper, a benzodiazepine taper, as opposed to someone with an alcohol use disorder. We can get them through acute withdrawal, typically, 3 to 7 days worst case. And they don't necessarily need a taper unless you needed to utilize really, really high doses of benzos. And so now you're concerned that, you have to taper what you were giving them. I think in general, we probably, for many patients, kind of overutilize benzos for withdrawal. The American Society of Addiction Medicine just came out with a new guideline for the treatment of alcohol withdrawal. And in that guideline, they point out the opportunity we have to reconsider or consider more strongly ambulatory detoxification. So I think that particularly as our hospitals are so full, we want to make sure patients are staying safe. So ambulatory detoxification may be an opportunity for us to really rethink how could we keep patients safe, still have good outcomes, but keep people out of the hospital. So there's some newer literature, some different protocols that you can utilize.
All right, excellent. In the interest of time, let's move on to case 2.
All right.
And Dr. Brigham, I've been missing your sweet baritone.
Absolutely. I'll go ahead and
why don't you regale us
butcher this
so I
one.
can be like going home again.
All right. So we've got Mr. Evan Doral, is a 25-year-old male with past medical history of opioid use disorder, IV drug usage, is admitted to the hospital for multiple epidural abscesses. And so I actually put the emphasis on the wrong syllable so it didn't copy over to the epidural. Did that just for you, Paul. As well as a splenic abscess, status post, IR-guided drain placement. He has started on IV antibiotics, and neurosurgery takes him to the OR for debridement of his abscesses. Afterwards, he still has 10 out of 10 pain despite receiving 10 milligrams of IV morphine every 4 hours. He reports interest in engaging in treatment for his opioid use disorder at discharge, but reports that he is in too much pain to think too far ahead. Infectious Diseases recommends an eventual 6-week course of IV antibiotics with a PICC line. So for this patient, how would you approach managing his post-op pain and his underlying opioid use disorder?
Thank you for this case and for that important question. So I will say that my training has really helped me turn this idea on its head. So when I started training, the adage was patients who have pain can't have opioid use disorder. If they have pain, it's sort of protective. They won't become addicted or have addiction. And we now know that that's not really true. So the training and my experience has shown that if we treat the opioid use disorder and the pain together concomitantly, we will have the best results. And I would challenge you to say that actually we have to treat the opioid use disorder before anything if we ever expect to get the pain under control. And the reason is that the patients who use heroin and fentanyl analogs have extremely high opioid tolerance. So the typical medications we use are just really not sufficient. And they're not long acting enough to really settle that down to treat the opioid debt that has occurred. So for this patient, I would want to talk to him about the different options. I would want to start those directly in the hospital. Ideally, I would like to start them before the surgery because we see that patients have better outcomes if we're able to kind of settle things down before any type of surgery. And then we also want to utilize multimodal treatment with other agents such as gabapentin, scheduled acetaminophen, NSAIDs. Ketamine can be really helpful in these cases. Probably not in this case necessarily because it's epidural space, but if this were, say, a septic knee, you could think about like a nerve block, things like that. All of these medications and treatments can help get the pain under control.
I'm curious. So I feel like so often I'll get a patient, right before they're going to go to the OR, I'll inherit them, or they're coming up from the ED and they're already on pain medicines. They've been getting pain medicines, because they have real pain. And I always struggle to think about, can I start? Is it really safe to start Suboxone if someone's already on opioids and that risk, that precipitating withdrawal? I'm curious how you sort of manage that if a patient's open to that option. It does sound like the ideal choice.
Right. So unfortunately, if they're already on opioids and they're coming to you, started on them because they were having severe pain, buprenorphine in that acute setting is probably off the table right away. That doesn't mean you couldn't switch to it later.
So that would generally leave you with methadone as a treatment option. And that would be totally fine, standard of care, to start them on methadone. If they were adverse to methadone for some reason, you could, in the hospital, utilize a longer acting opioid agent. But in my experience, methadone is actually one of the most effective medications to quickly treat opioid withdrawal.
And I think where I struggle is actually on the other side of things too. So you have someone who's post-op and they're having significant pain, and obviously you can't deny that, and maybe even interested in treatment for substance use disorder, but you have to get buy-in for the period of withdrawal that has to occur before you can make that transition. I wonder if you wouldn't tell me, sort of, first of all, how you manage that if the patient's open to it, and how you sort of frame that discussion, because it just seems like a really unappealing prospect, I would think. Because you have to sort of talk, listen, you're going to be without pain medications. We have to make you kind of sick before we can do this. There has to be a better way to say it than what I just said.
Yeah, that is a challenging conversation. So because it's so challenging, because many patients struggle with it, there are some new protocols we're using very low dose buprenorphine, starting that in the hospital where patients do not have precipitated withdrawal. It's been called microdosing. And so you can start extremely low doses of buprenorphine while the patient is utilizing the full agonist medication, and they do not go into precipitated withdrawal. There is a transition period, though, of typically of 5 to 7 days until they're able to switch to buprenorphine. So generally, when I'm talking to patients about this, I kind of frame it in one way. So I say, certainly if they're in writhing acute pain, I would not probably want to talk to them about this option. I would want to get things a little more stable, particularly because, this patient probably is going to be in the hospital for a bit of time while we're sorting out their treatment. So in a way, I feel better because I have a little bit of time to sort these things out. So I would get their operative pain under control or post-operative pain under control, and then, offer them methadone in the meantime, and then consider switching to buprenorphine at a later point. But once I get to that point where they're more stable, then the way that I usually talk to patients about it is I say, would you like to do this quickly, kind of like rip the Band-Aid, and it's, probably going to be 8 to 12 hours where you're not going to have exposure to an opioid. We're going to give you lots of other stuff. Or would you like this to be a much more gradual process? And patients typically kind of know how they're going to do, like which one's going to be better for them.
And what is there, obviously this is going to be individualized to patients, but when you say help them with other stuff, like practically speaking, what does that other stuff often look like?
Usually we're utilizing, so in that period of opioid abstinence, we're utilizing clonidine, hydroxyzine, scheduled Tylenol, NSAIDs, those sorts of agents.
Gotcha.
We may use a low-dose benzodiazepine if there's a lot of anxiety as well. That's one of the times that we, may utilize a benzodiazepine for that specific purpose.
So very helpful. Let's make him more complicated too. So let's say as you're getting Mr. Dural's discharge, you feel good about things, you have him in a good place, and you get a page from the nurse that's taking care of him, saying that they noticed Mr. Dural actually injecting drugs in his room. So obviously there's going to be hospital policies, but let's just take that out of the way. In terms of your initial approach, you go to actually talk to the patient. How do you care for someone who might be actively using drugs while in the hospital?
Great question, and a question and situation that is always, I think, distressing to all providers and care teams. So I think it is important to have a framework of how to address this. Usually this, to me, drug use in the hospital is a sign that something's going on that we're not addressing fully. And so for me, it's an opportunity to go to the patient, talk to them about what's going on. Are they having strong opioid craving? Are they having severe pain? Are they triggered to use because somebody just talked to them on the phone and they got really stressed out and they didn't know how to address it? What additional information do I need? So honestly, when I think it's important how you approach this. Again, everything we do in addiction medicine has to really be careful about the baggage we bring to it. So being as incredibly non-judgmental as you can, even if you don't like the behavior, you still need to support this patient because this is a sign that something's going on that we can address. So talking to the patient, getting their story, not being judgmental about it, offering help. And if they say, I don't want your help, you gave me methadone, it's not working, I don't want that methadone anymore, I'm done with this hospitalization, I just need to leave, then I say, okay, I hear you. Do you need some more methadone before you go? Are you sure we can't offer anything else that might help you? Are you going to be safe? How do I keep you safe? Then we think about what are the things that this person might need to stay safe. So do they have naloxone, for instance? Do they have a safe place to go? Do they have a clean water source if they're going to inject drugs? Do they have clean needles? Do they know where to get them? All of those sorts of things. So I go through that whole gamut. Many times, honestly, they'll kind of, as I go through that, they'll say, well, I'm not going to do that. Or, the situation will sort of diffuse just the longer you talk to them in a very nice way.
Sure. It's exhausting.
Yeah. They're like, please stop talking. I'll stay if you just stop talking. But anyway, the point being, how can you support them even if that support is to help to make sure that they are injecting safely? So our support can be in lots of different ways. If the patient agrees to stay, then we do typically want to think about how do we continue to support this person? So you generally, we do recommend that we are taking away the drugs that are in their room. So there generally is a room search of some kind. There may be some sort of agreement that you have with the patient. Some hospitals have patients sign these agreements. They are not contracts, they are agreements. You really want that agreement to be supportive in nature, not punitive. So those are some key factors of how to address this behavior. We don't typically rush into the room of a patient with diabetes who ordered cheesecake and rip their cheesecake out of their room.
No, that would be ridiculous. We have other cases to talk about. So I guess actually while we're on this one, let's say one last one, and I'll not talk at all for the next case. But Mr. Durrell, let's say we palliate things. He agrees to stay, have an uneventful course. You feel good about things at this point, and then we're kind of getting ready for discharge. And as we say, infectious disease has recommended 6 weeks of IV antibiotics through this PICC line for a patient with history of IV substance use. So I'm trying to think of the best way to ask this. So what's the calculus that goes into sending a patient home with a PICC line versus to a SNF, and sort of how do you make that determination as who is safe for what? Or and I'll leave the question there, I think.
Yeah, another great question, particularly as discharge planning for patients with substance use disorders can be very complex. Hence the reason that, you have teams who kind of specialize in this because we are encountering these barriers a lot. There are some criteria that we can utilize. There's a nice research paper out of University of Alabama that created a criteria. It's called the 9-point criteria for determining risk level of discharging a patient who has a substance use disorder home with a PICC line. So we do utilize that as a framework to develop a level of risk. It is not a hard stop. If patients have a safe place to go, they are agreeing to the care plan. They are on medication to treat their opioid use disorder. They have someone that they can partner with in their home who can make sure they're staying safe. They are in agreement with all of these follow-up plans, then many patients do quite well. And there is research to show this. And we probably are not utilizing this option enough. I think the challenging part is many of our patients, unfortunately, don't have stable homes. So that does create this level of complexity where we would love for them to be able to go home, but if they truly have an unstable environment, it's just really not safe. So you may think of other options such as new antibiotic regimens that are intramuscular, long-acting. Could you switch to those? Unfortunately, many of those are quite expensive and may not be covered by insurance, but it's always worth asking the question. And then there are some other options for infusion centers, particularly if the person doesn't need to be on the antibiotics as long. You could potentially have them come into a infusion center on a daily basis for a period of time.
And what was the name of the risk assessment tool?
The 9-point criteria. I believe Ellen Eaton is the primary author of that paper.
I've never heard of that, which is why I'm not an addiction medicine specialist, I guess.
I am happy to share it with you.
That would be outstanding. And we will certainly link to it in our show notes as well.
Shout out to the amazing ID addiction medicine trained people out there who do just such fabulous, amazing work.
So we're talking about Mr. Doral and sort of how to possibly transition him into and off of buprenorphine, but let's reframe things a little bit. Let's say he comes to us already on buprenorphine and feels like he's doing great with it, but does have these abscesses, does need operative management of them. I feel like this comes up all the time. What's the best way to manage a patient's perioperative pain if they already come to you on buprenorphine? And let's make it an even more ideal world. Let's just say that he did not come to you with any new medications on board from the ER. They just magically transported him up to the floor, and somehow he got away clean without having any new medications introduced. How would you manage this patient's pain?
Yeah, another great question, which we see a lot. So what I would recommend and what is increasingly recommended is to continue the buprenorphine in the perioperative setting. The error here would be to stop it, so continue it. There are some different opinions about how much you should continue, and we certainly need some more research in this area. Some protocols say you shouldn't continue more than 16 milligrams per day in the perioperative setting. However, I have had success with patients staying on their typical home dose, which could be up to 24 milligrams per day. So essentially, continue them on their buprenorphine, get them through their surgery, make sure you talk to anesthesia so they're aware of the potential need for additional high affinity agents intraoperatively. So those high affinity opioid agents would be hydromorphone and fentanyl or sufentanil, something like that. So those will competitively bind at the opioid receptor along with the buprenorphine, get the patient through their surgery. Post-operatively, we would continue to utilize those high affinity agents such as hydromorphone and fentanyl, typically at higher doses than you would typically utilize, so that the patients are getting analgesic benefit along with the multimodal approach. And in my experience, patients do so much better. They don't have withdrawal, they get pain relief, and then you don't have to worry about that situation of getting them back onto buprenorphine eventually.
Yeah, I just want to make sure I understand, because this feels like a really important point. So you've had the most success continuing the buprenorphine throughout, and then perioperatively adding things that have high affinity. So things like you're adding full opioid agonist therapy on top of like a hydromorphone specifically, that is something that you would add to their already sort of baseline Suboxone. Is that right?
That's correct. Yes. Okay. So you would continue the buprenorphine as they have in the outpatient setting, and then add the hydromorphone or fentanyl on top. You may consider, if they were taking the buprenorphine as a single dose, you may dose it twice to 3 times a day to take advantage of its analgesic benefit, which typically lasts somewhere between 6 to 8 hours, so that you're getting the most benefit out of the buprenorphine. So you're treating the opioid use disorder, and you're also utilizing its analgesic properties.
This may be a complicated answer, or maybe not, but what do you do with someone who comes to you on methadone therapy for their opioid use disorder? Do you change around their pain management regimen at all, or how does that impact what you would do perioperatively for them?
Again, we would continue it. If they came in and they were not doing well, such as using opioids additionally, such as heroin or fentanyl analogs, we would consider increasing the dose to stabilize their opioid use disorder, and then utilize full opioid agonists on top of the methadone. This would be another instance where you may split dosing. So you may say their dose is 50 milligrams. You may put them on 25 milligrams twice a day to get that analgesic benefit. Some patients really don't like that. So it's good to ask them, do you think this would help you? And they're generally pretty clear, whether they think it will benefit them or not.
Great. That's incredibly helpful. Okay, great. So let's move on to our last case.
And sorry, it was one thing. I think it's important to note that you can make adjustments to patients' methadone treatment when they are in the hospital. You do not have to have a special license or certification to do so. It's completely legal and safe. If you don't know how to adjust methadone, however, I would recommend that you reach out to someone who does have experience, such as maybe the medical director of the methadone program. The biggest issue I see around methadone management in the hospital is people, well-meaning, increasing doses too quickly, aggressively, and then patients getting sedated at day 3 to 5, because now the methadone has accumulated and now they're super sedated.
Wow, I can tell you at Cashlack Northeast, I don't know that anyone has any comfort with prescribing methadone at all. So if we have a dose that has been established, happy to continue it. But otherwise, in terms of dose adjustment, I think there's just not a whole lot of physician comfort in titrating that medication.
I actually manage.
So I can't imagine that'd be a problem to run to. What's that, Stuart?
I actually manage most of the methadone patients in our clinic, surprisingly. But
it's not all heroes wear capes. That is not our last case. We have one last case. Let's let the great Carolyn Chan read that one. So this will be our patient. We were calling her Qtc Prolongation.
Yeah.
Okay.
Yep. Just Qtc Prolongation. Yeah. The parents were very eclectic and decided to name them after an EKG finding. So we have a patient who's basically coming in who has history of opioid use disorder, who's on methadone as maintenance therapy. You're actually treating him for community-acquired pneumonia at this time. You get an EKG, and you actually find his QTC is 513, and he's also on levofloxacin. So you're sort of thinking that this prolonged QT is probably related to this interaction between his antibiotics that he's currently on and his methadone. So at Cashlack Midwest, I also don't have a lot of experience titrating methadone, to be truly honest. So I'm curious, how would you manage this patient's methadone treatment in the inpatient setting with his prolonged QT interval?
Great question. Comes up a lot. So generally, we try to keep the doses pretty stable because they're at that dose for a reason. That doesn't mean that you can't lower the dose if necessary. QTC prolongation in the setting of methadone typically does have a dose-related correlation. So you do see QTC prolongation typically at doses of 100 milligrams or greater. That being said, you want to check for reversible causes. That is the most typical reason I see patients having QTC prolongation on methadone. So are their electrolytes stable? Do they have a new liver abnormality that's causing this? is there a drug-drug interaction like you talked about? I also see many patients who come in with some sort of infection or illness. We just see this random QTC prolongation effect on their EKG. And so I also don't want to only react to that one QTC. I typically repeat it, particularly after we've addressed the reversible findings or causes. And then if it remained prolonged, I would talk to him about her about the risk versus benefit of reducing the methadone. And she may say, if you reduce my methadone, I 100% know that I will relapse. So then we kind of think, well, is it worth this small reduction for something we think that will improve to reduce her methadone? And so you just really have to kind of weigh that risk and benefit. If she says, I think I could probably go down to 90 and things would be okay, then I would reduce to 90. So I think, you do want to have a conversation with the patient. You don't want to just willy-nilly change their dose. I think it's cruel to reduce people's methadone in half or stop it entirely when they're in the hospital without having a conversation with them. I see that way too much. If you're not sure what to do, reach out for help. There are professionals, specialists who do this, and we'd be happy to talk anybody through it.
All right. I think that's a good place to wrap up, unless there are any other questions from the assembled masses here. This was a marathon, but I feel like we did a great job. So, Melissa, while we have you here, since you made about a bazillion great points, if you had to sort of narrow them down to just a couple, what would be your main take-home points for our listeners tonight?
I think the thing that we didn't maybe 100% address directly, but that we talked a lot about was initiating addiction treatment in the hospital, which is really vital for us to be able to utilize hospitalization as a reachable and significant moment in patients who are struggling, patients with substance use. So let's use that moment to start these treatments for opioid, alcohol, tobacco use. We have really amazing, really good medicines that work really well, and too few patients who are ever offered them. And the hospital setting is a unique place where we can really spend a little bit more time, reach a group that may not be willing to come to your typical sort of outpatient clinic. And this could be our opportunity to get them into treatment.
Anything you'd like to plug while we have you here?
I would love to plug the Yale program in addiction medicine. We have some CashLack hosts who are going to be coming to our program. We're super excited about. And then the American Society of Addiction Medicine has lots of amazing resources, particularly in the setting of COVID. They have created several different guidances of all sorts. So I would recommend people check that out.
Great. Thank you so much. This was really, really helpful. Thank you so much for your time.
Thanks.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Delicioso.
Not sure how I feel about that one. Get your show notes at thecurbsiders.com/podcast and sign up for our mailing list at thecurbsiders.com/knowledge food to get our weekly show notes in your inbox.
That's right, Paul, because we're committed to providing you with high-value, practice-changing knowledge. And to do that, we need your feedback, so please subscribe, rate, and review the show on whatever you listen to our show on. Or contact us at thecurbsiders@gmail.com. Special thanks to our producers for this specific episode, Carolyn Chan and Nora Toronto, and to our social media team, Beth Garbatelli on the Twits, Maddie Morgan on the Gram, and Chris the Jumanchu on the Book of Faces. Until next time, I've been Stuart Kent Brigham.
And we would be remiss in not thanking the great Dr. Stuart Brigham for composing the theme music that you are currently hearing, and a special thanks also to Claire Morgan of Nodderly for editing our audio. And as per usual, I remain Dr. Paul Nelson Williams. Thank you and goodbye.
Goodbye, Paul. Goodbye.
And thanks to our partner, VCU Health Continuing Education, who's helping us offer free CE credits for physicians and other healthcare professionals. Check out curbsiders.vcuhealth.org for more information.